Imagine going to your doctor, getting a simple blood draw, and being told you have the biology for Alzheimer's disease. Like, your entire world just stops.
Oh, absolutely. It's devastating.
Right. But now imagine finding out that test was wrong 40% of the time. Welcome to the deep dive.
Yeah, the fallout from that specific 2026 recall, it completely shifted how the medical community views diagnostic tools.
It really did. We went from widespread celebration to extreme caution practically overnight.
We really did.
So today, we are exploring the totally new era of Alzheimer's disease as of spring 2026. We've got a massive stack of sources in front of us.
A huge stack, yeah. Clinical guidelines, FDA prescribing info.
Exactly, and the latest medical news from the big neurology conferences. And we are here to map out this landscape for you, because keeping up with medical breakthroughs can feel like, drinking from a fire hose.
It's a lot for anyone to process.
Especially in neurodegeneration. So our mission today is to cut through all that noise, because the way we handle this disease has fundamentally changed.
For sure. I mean, for decades, Alzheimer's care was essentially just a waiting game.
Right.
We diagnosed it based on memory tests and cognitive symptoms, and we only treated those late-stage symptoms. But looking at these 2026 guidelines, that paradigm has been entirely dismantled.
Which is such a relief. So what are we doing now instead?
Well, we are now biologically staging the disease. It's a lot like how oncologists stage cancer, And we are using therapies that actively intervene to modify the brain itself.
Okay, let's unpack this. Because to understand how we treat it, we first have to understand how we find it. For years, Alzheimer's was diagnosed almost by elimination.
Right.
Yeah.
Ruled everything else out, and whatever was left must be Alzheimer's.
Yeah, exactly. But today, we rely on the ATN framework.
Right, the ATN framework. That stands for amyloid, tau, and neurodegeneration.
And these are the actual physical hallmarks of the disease.
Exactly. Amyloid plaques are these abnormal clumps of protein that build up in the spaces between nerve cells.
And then there's tau.
Yeah, tau tangles are twisted fibers of a completely different protein that build up inside the cells themselves.
And the N, neurodegeneration?
That's the resulting structural damage, like the actual shrinkage or atrophy of the brain tissue.
Wow.
And here's the kicker. To even initiate these new disease-modifying therapies we're going to talk about, a patient must have verified biomarker confirmation of this specific pathology.
So you can't just guess anymore based on memory loss.
Not at all.
So how do we actually get that confirmation? Because historically, looking for amyloid and tau meant a spinal tap, which is invasive and painful.
Very painful, yeah.
Or a highly specialized PET scan that could cost thousands of dollars, right? And it wasn't always covered by insurance.
It was a massive barrier to entry for care.
But then, just in the last year or so, we saw this massive explosion of blood tests. It sounded like a transformative leap forward, just a quick blood draw at a standard primary care clinic.
And, I mean, there have been some genuinely incredible advancements in that space. Take the Alexis Tau 181 test from Roche, for example.
Right, the FDA cleared one.
Yeah, cleared in late 2025, specifically for the primary care setting.
Yeah.
And its greatest strength is its negative predictive value, which sits at an impressive 97.9%.
Oh, wow. So meaning if you're listening to this and you take that test and it comes back negative, you and your doctor can be almost completely sure your memory issues are not being caused by Alzheimer's amyloid plaque.
Exactly. It directs the investigation elsewhere.
Right. Maybe to a vitamin B12 deficiency or thyroid issue.
Or severe sleep apnea.
Yeah.
It spares patients the anxiety and the financial burden of further, more invasive Alzheimer's testing.
That is huge. But the complication arises when the tests start reporting positive results, doesn't it?
Yeah, that's where things got messy. The blood biomarker boom hit a severe speed bump recently with the Lumipulse Pito 217 and a Beta 42 test.
Yeah, we have to get into this recall because this test was cleared by the FDA in mid-2025 and the medical community was thrilled.
Everyone was so excited.
But by early 2026, it gets hit with a major Class 2 FDA recall. What exactly happened?
Well, the data presented at the clinical trials conferences late last year revealed a massive vulnerability. There was a manufacturing issue with specific lots of the test.
A manufacturing issue.
Right. Essentially, a calibration drift in the chemical assay caused the test markers to bind to benign non-Alzheimer's proteins in the blood.
Oh, no. So it couldn't tell the difference.
Exactly. The test couldn't tell the difference between normal cellular exhaust and actual Alzheimer's pathology. In one cohort at the Mayo Clinic, the false positive rate hit nearly 40%.
That is terrifying. Just imagine getting that false positive. To me, using these blood tests is a lot like using a metal detector at the beach.
Oh, that's a good way to look at it.
Right. Like, they're fantastic for broad screening. Like the Alexis test, if the detector doesn't beep, you know there's no metal in the sand, and you can just keep walking.
Yeah, you're cleared.
But if that detector does beep, you can't just trust the noise. Because of things like the Luma pulse recall and Adsay drift, you still have to dig in the sand to confirm what's actually down there.
This raises an important point about the new standards. If that metal detector beeps, the 2026 guidelines dictate a strict protocol.
Which is?
Blood tests are adjunctive tools. They're just the initial flag. If a blood test suggests Alzheimer's pathology, you absolutely need that PET scan, or cerebrospinal fluid testing, to physically see the pathology.
Before you ever consider putting a patient on serious medication.
Exactly. You have to verify.
So let's say we've gone digging in the sand with our PE scan and we've actually found those amyloid plaques. The immediate question is, how do we get them out of there?
That's where the heavyweights come in, the disease-modifying therapies, or DMTs.
Right. And there are two major FDA-approved therapies currently dominating the market, right?
Yes. Leqembi, which is lecanemab, and Kisunla, which is donanemab. Both are monoclonal antibodies.
Okay, let's give a quick definition there for anyone who doesn't know. Monoclonal antibodies are basically lab-made proteins, right?
Yeah, essentially.
Scientists identify an antibody that naturally fights a disease, clone it in a lab, and mass produce it so it acts like a targeted strike force for your immune system, hunting down one specific molecule.
That's a great summary. And in this case, the target is amyloid. But their underlying philosophies and the actual biological mechanisms they use to attack the amyloid are surprisingly different.
How so?
Well, Kisunla goes after the hard, already formed amyloid plaques in the brain. Because it targets the end-stage garbage, it's designed as a finite treatment.
Finite meaning it stops.
Right. A patient receives the infusions, gets monitored with PET scans, and once the plaque is cleared below a specific visual threshold on the scan, they stop taking the drug entirely.
Which sounds incredibly appealing. I mean, you go in, you clean up the mess, and you leave.
It's very attractive to patients.
But Leqembi operates on a totally different principle. It targets what are called a beta protofibril.
Yeah, the precursors.
Right. They are the sticky, toxic little building blocks that haven't yet clumped together to form the hard plaques. And because Leqembi targets the precursors floating around, it's designed as a continuous treatment.
Right. You clear the plaque, but you stay on the drug to intercept the building blocks and stop new plaques from forming. Think of the brain like a kitchen sink where the faucet is left running.
Okay, I'm picturing it.
Kisunla is incredibly effective at pulling the plug and draining the water that's already in the sink. But if you don't turn off the faucet, the continuously forming protofibrils, the sink will eventually fill right back up.
So Leqembi is like a filter.
Exactly. By targeting those precursors continuously, Leqembi acts as an ongoing filter, catching the water before it hits the basin.
But let me push back on that continuous model for a second, though.
Sure.
If I'm a patient or managing care for a parent and Kisunla lets me stop going to the clinic once the plaque is gone, why on earth would I sign up to stay on Leqembi forever?
That's a fair question.
I mean, going to an infusion center every 2 weeks for the rest of my life sounds exhausting.
It does. But the clinical data supporting this continuous approach is compelling enough that many patients choose it.
The 4-year data, right?
Yeah, the highly anticipated 4-year data presented at the ADPD 2026 conference. It showed that continuous Leqembi treatment resulted in a 9.8-month delay in overall disease progression compared to untreated control groups.
A 9.8-month delay in losing your memory or your independence, that is massive for a family.
It's huge, but the headline that really jumped out of our sources was a specific subgroup in that trial.
Oh, the early stage group.
Yes. In patients who were at a very early stage of the disease and specifically had low levels of tau protein, an incredible 73% of them had no cognitive decline over 4 full years.
Wait, really? 73%?
73%. 4 years with a flat trajectory on a cognitive decline graph is unprecedented in an Alzheimer's trial.
It is just, wow.
And pharmaceutical companies also recognize the logistical nightmare of lifelong IV infusions. So in August 2025, the FDA approved a subcutaneous maintenance autoinjector called Leqembi IQ-LIK.
Oh yeah, I've seen the specs on this. It's a weekly injection a patient or caregiver does at home, kind of similar to an EpiPen.
Very similar. And the actual administration takes about 15 seconds.
15 seconds. That completely changes the game.
And as of the spring 2026 sources we are reviewing, the FDA is evaluating an application to allow patients to start with that at-home injection from day 1, skipping the IV phase entirely.
That's incredible.
High real-world persistence rates in the U.S. demonstrate that if you show patients a tangible benefit and you remove the friction of the clinical visit, they are overwhelmingly willing to maintain continuous therapy.
I mean, 73% of early-stage patients seeing no decline, 15-second at-home injections. It's easy to look at this and think we've solved it.
But we haven't.
Right. We have to look at the collateral damage because these drugs are essentially blunt instruments. They do the job of clearing plaque, but they leave a mark.
They definitely do.
They come with strict boxed warnings from the FDA, mandatory heavy monitoring, and intense debate regarding a side effect called ARIA.
Right. ARIA stands for amyloid-related imaging abnormalities, and it manifests in two main forms.
Okay, let's break this down.
ARAE refers to edema, which is fluid leakage causing swelling in the brain tissue.
Swelling in the brain. Got it.
And ARAH refers to hemosiderin deposition, which indicates microhemorrhages or small bleeds in the brain.
So what does this all mean? Let's explain how that actually happens. Why does clearing a protein cause your brain to bleed?
It really comes down to where the amyloid is located. In many Alzheimer's patients, the amyloid doesn't just clump between the neurons, it actually embeds itself into the walls of the brain's blood vessels.
It replaces the smooth muscle tissue, right?
Exactly. So when these powerful monoclonal antibodies enter the brain, they attack and rip the amyloid out of those vessel walls.
Leaving behind a porous, weakened blood vessel.
Exactly. The vessels become leaky. If blood plasma leaks out, you get the swelling of AR8. If red blood cells leak out, you get the microhemorrhages of ARAH.
And do patients feel this happening?
For many patients, it's totally asymptomatic. They only know it's happening because it shows up on an MRI. But for a subset of patients, it causes severe headaches, confusion, visual changes, and in rare cases, life-threatening seizures or massive hemorrhages.
Which is terrifying. So if you're listening to this and wondering if you should get genetic testing before trying these drugs, the data says yes.
Oh, absolutely yes.
Because your risk for these brain bleeds isn't random, is it? It is heavily tied to the ApoE gene.
Right. Every person inherits 2 copies of the ApoE gene, one from each parent. Inheriting the ApoE epsilon 4 variant increases your general risk for developing Alzheimer's.
Right, we've known that for a while.
But if you are an ApoE4 homozygote, meaning you inherited that specific epsilon 4 variant from both your mother and your father, your risk for severe ARIA skyrockets.
Wait, why does having 2 copies of the gene make the bleeding so much worse?
Well, homozygotes naturally accumulate a significantly higher volume of amyloid, specifically inside their blood vessel walls.
Oh, so there's just more to rip out.
Exactly. When you introduce a drug like Leqembi to a brain with heavily embedded blood vessels, the resulting structural damage from clearing that amyloid is much more extensive. Symptomatic ARIA occurred in about 9% of homozygotes in the Leqembi trials.
9%.
Yeah, compared to just 2% of heterozygotes and 1% of non-carriers.
Which is why the guidelines heavily recommend genetic testing, so you know if you are in that high risk. 15% of Alzheimer's patients who are homozygotes.
It's vital information.
And honestly, regardless of your genetics, the monitoring is a heavy burden. I mean, to safely administer Leqembi, a patient has to get an MRI before their 3rd, 5th, 7th, and 14th infusions to constantly check for these invisible bleeds.
A lot of MRI time.
It is. And this incredible cost and logistical strain is the epicenter of a fierce controversy. Like, is the benefit actually worth it?
And that's exactly what the April 2026 Cochrane Review dug into. It ignited a massive firestorm over that exact question.
So Cochrane reviews are widely considered the gold standard in evidence-based medicine, right?
Yes, they perform what's called a meta-analysis. They gather all the available clinical trial data on a given medical topic, pool it together, and analyze the aggregate data to provide a definitive answer.
And they looked at the entire class of anti-amyloid drugs and concluded that the cognitive benefit to patients is, and this is their direct quote, trivial.
Yeah, trivial. That word caused an uproar.
They argued that across 17 trials and over 20,000 participants, the difference in cognitive function was clinically meaningless to the patient's daily life.
But researchers and major Alzheimer's organizations pushed back relentlessly. Now, we are just reporting the debate here, not taking sides. But the fundamental argument against the Cochrane Review targets its methodology.
How they pooled the data.
Right. When you pool data in a meta-analysis, the statistical power is incredible. But if you mix highly effective trials with completely failed trials, the noise of the failures grounds out the signal of the successes.
Because the researchers pointed out that Cochrane pooled data from the newer successful drugs like Leqembi and Kisunla, together with data from a whole generation of older antibodies.
Drugs like bapineuzumab and crenezumab.
Right, which failed to effectively clear amyloid or slow the disease years ago. It feels a lot like trying to figure out the average processing speed of a modern smartphone. But the reviewer pools the data by including benchmark tests from a 2005 flip phone.
That is a perfect analogy.
Like, you mix the latest iPhone with a Motorola Razr, average them out, and conclude that mobile technology is just okay.
Exactly. By blending the old failures with the new breakthroughs, the drug developers argue the review completely obscures the reality of modern therapies. Regulatory bodies like the FDA, the European Medicines Agency, and the UK's MHRA have analyzed the newer drugs in isolation and concluded they do offer a meaningful, albeit modest, benefit.
But the Cochrane review still serves a purpose, does it?
It definitely does. It acts as an anchor. It reminds the field that even the best data from Leqembi is not a cure. It is a modest slowing of decline for very specific, thoroughly screened patients.
So if attacking amyloid with these antibodies is a blunt instrument that causes bleeding, and the cognitive benefit is fiercely debated, where do we go next?
Well, the researchers in these sources aren't giving up. They're engineering completely new delivery methods to bypass these risks.
Here's where it gets really interesting, because the blood-brain barrier is the next great frontier, isn't it?
It is. The brain is an incredibly secure fortress. It's designed to keep foreign molecules out to protect our neurons.
Which is good most of the time.
Usually, yes.
Yeah.
But conventional antibodies like Leqembi have a terrible time crossing that barrier. Physicians have to pump massive amounts of the drug into the patient's bloodstream just to get a fraction of a percent of it to actually penetrate the brain.
Which is highly inefficient, and having all that excess antibody floating in the bloodstream and the blood vessels likely contributes to the side effects.
Exactly. But the sources highlight a revolutionary new drug from Roche called trontinemab. The scientific community is calling it the brain shuttle.
The brain shuttle? That sounds like sci-fi.
It really is a stunning piece of bioengineering. Trontinemab physically attaches the anti-amyloid antibody to a molecular fragment that binds to transferrin receptors.
All right, wait, slow down. If the brain is designed as a fortress to keep everything out, what is this transferrin receptor, and why does the brain let it through? What's the loophole here?
Well, the brain needs iron to function properly, right?
Right.
Transferrin receptors are active transport gates built into the blood-brain barrier, specifically designed to shuttle iron from the bloodstream into the brain tissue. Trontinemab hijacks this natural mechanism.
Oh, that's clever.
It binds to the gate, and the brain actively pulls the drug across the barrier, assuming it's bringing in iron.
It's a Trojan horse.
It really is, and it transports the antibody across the barrier roughly 50 times more efficiently than standard IV infusion.
50?
Yeah, and the phase 1b and 2a data presented in late 2025 were staggering. Because so much of the drug successfully reached the target, about 91% of patients on the highest dose became entirely amyloid negative in just 28 weeks.
91% cleared the plaque in half a year.
Yes. Furthermore, because the drug is actively pulled into the brain tissue rather than getting caught up in the blood vessels, it doesn't cause the same vascular damage. The ARIE rates, the brain swelling, were under 5%.
That is a massive leap in safety and efficacy. But as the 2026 guidelines make clear, simply removing amyloid isn't the entire solution. To really halt this disease, we have to look at combination therapy, right? Specifically targeting the brain's immune system. The microglia.
Yes, the microglia. They are the brain's primary resident immune cells. Their baseline job is to patrol the neural pathways, clean up cellular debris, and maintain healthy synapses.
I always picture microglia like the video game character Pac-Man.
Oh, I love that.
Normally, you've got these helpful little Pac-Men wandering around the brain, eating up the trash, keeping the neighborhood tidy. But when they're constantly exposed to amyloid plaques over years, they experience a biological software glitch. They become hyperactivated. They stop being helpful Pac-Men and turn into the ghosts.
What's fascinating here is the mechanism behind that glitch. It's chronic neuroinflammation. When microglia become hyperactivated by the amyloid, they start secreting massive amounts of inflammatory cytokines.
Cytokines, okay.
Yeah, they're basically chemical distress flares that call in more immune activity. This creates a runaway inflammatory loop.
So they overreact.
Big time. Instead of just clearing the plaque, the inflamed microglia start attacking the healthy tissue. They literally melt away the brain's synapses in a barrage of friendly fire.
Wow.
And this chronic neuroinflammation often drives cognitive decline even faster than the amyloid itself.
So a huge area of research right now is figuring out how to tame those microglia. Like, how do we reboot their software and stop the friendly fire? The sources highlight specific new targets, like the TREM2 receptor and the cannabinoid receptor type 2, or CB2.
Right. The Alzheimer's Drug Discovery Foundation heavily emphasized these targets in their recent consensus reports. Take a compound like NTRX-07, which binds to the CB2 receptor.
What does that do?
Well, preclinical studies demonstrate that activating this receptor can actually force the microglia to shift out of their toxic pro-inflammatory state, what we call the M1 phenotype, and revert back to their neuroprotective plaque-clearing M2 state.
It physically turns the ghosts back into Pac-Men.
Exactly. And when you map out these different mechanisms, the future of Alzheimer's care comes into sharp focus. Just think about it. We don't treat cardiovascular disease with just one pill, right?
Right. A patient might take a statin to lower cholesterol, a beta blocker to reduce blood pressure, and a blood thinner to prevent clots.
Precisely. The future of Alzheimer's is a customized combination approach. A patient might take a brain shuttle to efficiently clear the amyloid, a secondary drug to prevent the tau tangles from forming, and a microglial modulator to keep the brain's immune system calm.
That is it's incredible. Let's take a breath and recap this amazing journey. If you are navigating this landscape, the main takeaway is that the diagnostic muddy waters are clearing. We've moved away from wait and see. We are biologically staging the disease with the ATN framework.
It's a whole new world.
It really is. We have primary care blood tests that can rule out amyloid with near-perfect accuracy, provided we verify positive results to avoid manufacturing errors. We have treatments like Kisunla with finite stopping points, and continuous protections like Leqembi that will soon rely on 15-second auto-injectors in your own kitchen. And on the horizon, we have Trojan horse brain shuttles and drugs that reprogram the brain's immune system.
This represents a profound shift in clinical neuroscience. And the reason this matters to everyone right now is that all of this technology is aggressively pushing us toward a true prevention paradigm.
Prevention rather than just delaying it.
Yes. Major trials like AHEAD 345 are currently testing these exact anti-amyloid drugs on cognitively normal individuals.
Wait, normal individual?
Yeah, people who have amyloid silently building up on a PET scan but experience zero memory loss yet. The ultimate clinical goal is to intervene and halt Alzheimer's before the very first symptom ever appears.
To keep the structural integrity of the brain pristine from the start, that's beautiful. But before we wrap up this deep dive, we want to leave you with a final, slightly provocative thought to mull over. Something that is buried in these 2026 updates, but really puts all this high-tech, expensive science into perspective.
Yeah, it raises a fascinating question. Can you outrun Alzheimer's better than a blockbuster weight loss drug can?
Let's explain that. In late 2025, the medical world was buzzing about the EVOKE trials. Researchers were testing oral semaglutide, the exact same class of GLP-1 drug as Ozempic and Wegovy, to see if its metabolic benefits could slow Alzheimer's disease. And it completely failed.
It did absolutely nothing to slow cognitive decline.
Nothing at all.
Yet, just months prior to that failure, the results of the U.S. Pointer trial were published. This was a massive trial testing a structured, multi-domain lifestyle intervention. We're talking rigorous physical exercise, strict adherence to a Mediterranean-style diet, intensive cognitive training, and aggressive management of cardiovascular risk factors like blood pressure.
So no sci-fi brain shuttles, no GLP-1s, just diet, exercise, and social engagement.
Exactly. And it succeeded. It produced real, statistically significant global cognitive gains in older adults who were at high risk for dementia.
It's an incredible contrast to end on. It leaves you wondering as we wait for the perfect, side effect-free, transfer and hijacking antibodies to finally hit the market. The absolute best combination therapy right now might just be pairing our current medical science with a strict Mediterranean diet and a really good pair of running shoes.